Okay, again, so again, we're here to talk with Dr. Heather Harle, the interim stroke medical director for the Lancaster General Health Penn Medicine Stroke Program. Dr. Harle joined the staff at Lancaster General Health Physicians Neurology in 2011. She has a bachelor's degree in science from Franklin and Marshall. She's a graduate of the Thomas Jefferson University Sidney Kimmel Medical College. In 2006, she completed her neurology residency in 2010 and a clinical neurophysiology fellowship in 2011 in the University of Virginia Health System. Dr. Harle is board certified in neurology since 2011 and currently serves as the interim medical director for Penn Medicine Lancaster General Health Stroke Program, in addition to her full-time job. So, Dr. Harle, I can't imagine how much pressure you have, how much additional work you have, but we appreciate.
Tracy does work for me, so I just need to give the kudos to her. She just makes me show up for things once in a little while and makes me put signatures on things.
I'm sure. None of us could survive without Tracy. So I'm going to go ahead and I'm going to log off, or not log off. I'm going to mute myself and turn this over to Dr. Harle. So I appreciate it very much. And again, for those of you that just joined, please add your name, first and last name, and your certification number in the chat area so I can, or we can give you proper continuing education credit. Thank you, Dr. Harle.
Thank you, Andrew. Is my presentation showing up now for everyone? Is my screen showing?
Yes,
Andrew?
ma'am. Yes, ma'am, it is.
Okay, so we're ready to go then.
Okay.
So thank you for having me tonight, and Happy New Year, everyone. Thanks for all you do to keep Lancaster County safe and healthy, of course. And I did want to say that I am not going to take an hour and a half tonight, I believe. I had some big shoes to fill, of course, coming in after Murray Flaster, who certainly could fill an hour and a half of talking with a lot of humorous stories, which is not me. I didn't grow up anywhere fun, and I don't have a good New York City accent with tons of stories from back in those days. So hopefully you find this interesting, just not, it won't be quite what it would have been if Murray was doing it. If you have any questions, because I'm not explaining things well enough, just let me know. I'm going to do my best to kind of talk to you as though you're family members, students that are learning, and try and bring it to the right level. But if I overshoot, just let me know and I can try and do better. Okay, so today we're talking about stroke in general. I'll go over definitions of stroke and TIA, and give you some basic learning about ischemic and hemorrhagic stroke and what they look like. We'll then, after we do probably 15 or 20 minutes of that, talk about the meat of what you wanted to hear stroke mimics. That's about 7 or 8 things we're going to go through step by step that look like stroke but actually aren't. And then I threw in a few chameleons at the end. These are things that actually are stroke but don't appear to be so when you first see them. So what is a TIA? 30 years ago, everyone defined TIA as a neurologic episode that lasted less than 24 hours. That was the old school definition. That's not at all correct anymore. Now we know it really doesn't take very long to kill tissue in the brain that we can see on MRI. So they redefined it in 2002 to be an episode of neurologic dysfunction. Of course, it could be in the eye or the brain due to ischemia, with clinical symptoms lasting usually less than an hour, or if we do what's called an MRI with diffusion-weighted imaging, that's a certain set of pictures we capture, and then the dead tissue shows up as bright white. So certainly if it's been without oxygen for an hour, sometimes even less than 20, 30 minutes, the tissue will be dead on MRI and we can see it. So the symptoms may be resolving, but if we can see that spot on the MRI, we'll know that it was a stroke. So, as mentioned, it's neurologic dysfunction. We're going to talk about stroke in the brain as sudden onset of symptoms, not symptoms that are marching, not symptoms that are coming on over the course of an hour, not symptoms that are hard to tell exactly when they began. In stroke, symptoms begin very suddenly. It's very clear when it begins. It was there 1 second, not there the minute before. And the symptoms need to make sense. The brain is topographically organized. So strokes will fall into a discrete pattern of syndromes based on the organization in the brain. It's usually some combination of things such as aphasia. Aphasia is the when a patient doesn't seem to be able to find the right words, like I just did there, or the words they're saying don't make much sense. So they can have aphasia, they can have neglect. Neglect is usually when a patient has a right hemispheric infarct and then they don't know that they have a left half of the world or a left half of the body. So their new world is sort of only the right side of the world. They will have some combination of face, arm, leg weakness or numbness or both. Dysarthria is slurring of the speech. Diplopia is double vision. Dysphagia is difficulty swallowing. Vertigo, like when you drink too much alcohol or on a merry-go-round and the room is spinning, and or gait changes. On the left here, we have what we call the homunculus. So when you're looking at the brain, and we're cut sagittally in this image, so that means, can you see my cursor? I hope you can see my cursor. My cursor is over where the ear would be if you're looking at your head to the side. This right here is a temporal lobe where the ear would be sitting. This is the brainstem, this is the cerebellum, this is the back of the head, and this is the front. So if you're looking through this area right here and you blow it up over the motor strip, down in the center of the brain, we have the control of the leg. This is in the sulcus between the two halves of the hemisphere, so down deep in here. As you're coming over the side of the brain over here, this is the control of the hand and arm. And then as we're coming down here towards where the brain is under the ear on the left-hand side, this is the control of the face. So we can guess based on where a patient's symptoms are often, based where the symptoms are as to where the stroke would potentially be. So on this motor strip right here, again, face, arm, and then deep down in the center is where the leg is controlled. Now, this is a demonstration of what we call Brodmann's areas on the right. And every little area of the brain is similar in people. That this gyrus right here, number 44, for instance, is Broca's area, the language area. And then back in here in the 40 and 41 area is Wernicke's area. That's where you have the aphasia where you can say word salad, a ton of words that don't make sense. Whereas in Broca's area 44 on the left hemisphere is where you're going to have an inability to get all your words out. The visual cortex is here in the occipital lobe in the back of the head for everyone. And then those are sort of the main ones. On the right half of the brain, so if you flipped this around, these areas would be that neglect area we talked about where you wouldn't necessarily know you have a left half of the body. So if you put a stroke right up in here, this is where your patient presents where their hand is weak. If you just have a little ditzel right up in here. If you have a little ditzel in here, there's going to be language issues as well as facial weakness usually with this area. And then down deep in the center of the brain is where the patient will have primarily leg weakness. Back in here is where we have our strokes where people lose vision to one side of the world. And remember, the big key here is the left controls the right body and the right brain controls the left body. Most people have their language in the left hemisphere. Pretty much all right-handed people and the vast majority of left-handed people as well all have their language in the left hemisphere. Okay, stroke can be ischemic. That's the majority of what we see. That means stroke where a clot has formed or traveled into the brain and blocked blood flow. That's 85% of stroke. Or we can have hemorrhagic stroke. That's 15% of stroke. So that's where you have a blood vessel that bursts open and blood fills the brain, takes up space, and causes the neurologic deficits. Stroke is the third leading cause of death in this country, a major cause of disability, obviously. 1 in 10 people over the age of 75 have had a stroke. There's probably at least 750,000 strokes each year in America, and most stroke is not immediately fatal. In the first 30 days, only 7% of ischemic stroke patients, but 37% of hemorrhagic stroke patients will die. So obviously, the majority of our strokes are ischemic, and most of those people will be living with disability afterwards versus in the case of hemorrhagic, which are the minority of our strokes, at least a third of those patients will die within the next 30 days. in all, 20% of those surviving will require facility care. Sorry, CARE. Ischemic is what neurologists get the most excited about because we have treatment that I'll talk about some more. But just to give you a brief overview of ischemic, which is the clot-related stroke, about half of those that we see are what we call lacunar. These are these little spots on the MRI imaging. They're small, and they're usually in pretty typical areas. This is a common area. In here, where you see these red spots, are all these areas where, as we age, if we have blood pressure issues, cholesterol issues, if we smoke, we have diabetes, all of those areas will harden first. And when you have these lacunar strokes in these areas, although they're all different areas of the brain, the syndromes are usually fairly consistent. So these are the patients who come in with Miller syndromes defined by C. Miller Fisher, a famous neurologist, that consist of face, arm, and leg of pure motor weakness, face, arm, and leg pure sensory loss, mixed face, arm, and leg motor and sensory changes. So they're weak and they're numb in their face, arm, and leg. This one in particular right here would be a very common one for making a patient show up weak in the face, arm, and leg. They may have slurred speech and a clumsy hand on their finger to nose, or they may have a weak leg and be ataxic with walking. This one we see less often, but these are the majority of your lacunar syndromes. So these are our 80-year-old patients, our 70-year-old patients who smoke with hypertension or hyperlipidemia, often what they come in with. So these patients, when they're small strokes in these areas, do not have aphasia. They do not have neglect, okay? That takes getting areas on the cortex that we'll talk some more about. So these patients with acute onset of face, arm, and leg weakness or numbness, for instance, are often having a lacunar ischemic stroke. Now, when the patient looks a lot worse and they're neglecting the left half of the world, for instance, along with having the face, arm, and or leg weakness, they may be having a bigger ischemic stroke. Now, these are the strokes that instead of being caused by a hardening of a small artery in the brain from those risk factors, may be caused by a clot. This is an MRA of the brain showing the right blood vessel here called the MCA stops because there's a clot stuck right here. And by sticking a clot in this larger blood vessel instead of the teeny tiny one like on the left scan is causing an area of decreased blood flow to a very big portion of the right hemisphere. So these are your patients who have sudden onset, in this case, since it's right MCA, of left face, arm, and leg weakness, along with neglect of the left body. So they're laying on the floor, laying on this stretcher, and their head is turned to 45 degrees off the bed on the right because they no longer seem to know that they have a left half of the world. So from straight ahead to the stretcher on the left side of their body, that world doesn't exist anymore. They don't know they have a left arm. They can't see to the left. So this is classic for an MCA stroke. And these are very devastating strokes for patients, harder to rehab than the last one I showed you that was a lot smaller. The reason it's important to be able to find these strokes is because we as neurologists can treat them when you get them into us. The treatment is called TPA, tissue plasminogen activator. TPA is a naturally occurring enzyme in our bodies that breaks down clot. But of course, pharmaceutical companies have engineered it now and sell it to hospitals for about $1,500 a dose. It's approved for stroke along with pulmonary embolism and MI, although it's very rarely used for MI and occasionally used for saddle pulmonary embolism. Time is brain, so we treat quickly once we get a scan of the head that shows there's no blood when we suspect that someone has a lacunar syndrome. Key to the decision, as you know, is the time of onset of the stroke, when the patient was last known well. So not when somebody finds them looking like they have a stroke, but when they actually were seen 100% normal. So sometimes we can get the story that it happened at exactly 8 p.m. The patient can tell you they looked at their watch. But unfortunately, sometimes, as you know, maybe it was the night before when they went to bed was the last known well and they woke up with the symptoms. But we always start the clock at the last known well. This is important because if we treat with TPA when the stroke is too old, the patient will bleed. Our window is definitely less than 3 hours, and in many cases out to 4.5 hours, we can treat these patients as long as it seems like the syndrome is consistent with the ischemic stroke. And there's no other risks for bleeding, like recent surgical procedures, a recent stroke, or recent heart attack, if they making sure they don't have brain tumors or other new cancer diagnoses that are at risk for them, etc. So we know giving TPA is helpful because it's been proven to make it more likely for our patients.
Answer the alarm. Fucking piece of shit.
That our patients can take care of their own activities of daily living. So we need to be able to see when the patient comes in there within the window for TPA, and they need to have a syndrome that makes sense, came on acutely, it didn't march. We'll talk some more about that as well. Now, in the last, Tracy can correct me if I'm wrong because I'm blanking on the time now, but I believe it's 2 years now. In October, we've had endovascular therapy at LGH. This is select treatment for patients with stroke out to 24 hours who may be candidates for a procedure to restore flow when they're the second case that I showed where there's a big clot sitting in a blood vessel like the MCA. So looking at all the data going back in time since 2015, so this is a newer approved treatment for stroke, we've had 6 trials prove we can help these patients if we carefully select them. As mentioned, you don't want to mess around in the brain and do things. If the tissue is dead, patients will have bleeding in the brain and it's high risk. So what this trial has shown, if we use careful selection using CT perfusion and angiography, which I'll show some pictures here in a second, and we do endovascular treatment to put a catheter in the groin and suck out the clot that's in there, you only need to treat 2.6 patients in order to reduce disability over time. So you actually have to give, maybe 90 people aspirin to save 1 stroke, but you only need to do 2.6 treatments of endovascular to really improve quality of life for 1 person. So the number needed to treat in endovascular therapy is very low, meaning that it's a tremendously beneficial intervention that we have in our toolkit here at Lancaster General. So this is the classic situation when someone wakes up with stroke. In the past, their last known well was the night before. They're well outside of the 3-hour, 4.5-hour window. Previously, we would have nothing to offer to them. We wouldn't be able to give them IV TPA. But now we can do this type of angiography. We put the dye in their arm and capture images. And if we see a big mismatch between tissue that's dying but not dead, then we can potentially go in and salvage it. So Dr. Ram Shivali was the interventionalist. He's a radiologist that's specially trained to put these catheters in and suck out clot that Dr. Flaster had brought here to LGH. Dr. Shivali has now had Dr. Bergoglio trained as well. So these are the pictures that we get sent to our cell phone after the images are captured on the CAT scan emergently in our stroke alert. So on the left-hand side here in purple is what we call the core. These are CT scan images from the base of the brain. We're moving up, all on the purple here. So from the bottom up to the tippy top of the head up here. So here on the left-hand side of the brain, so this looks like a clot got stuck in a left middle cerebral artery, is an area of purple meaning dead tissue. So this is tissue that likely may not be salvageable. But if there's a big clot in there and it's early enough and the patient is lucky, sometimes there's still a lot of tissue that hasn't died. Over here on the right, you'll see in green a much larger area of what we call tissue at risk. So in this patient's scan, it's actually a good candidate to go in for Dr. Shivali and try and suck out the clot that's sitting in there because there's a lot of area to salvage and only a smaller area that's already dead. Many times when we get this scan, there's not even any purple there yet. It may be early enough that there's no tissue that's already dead and just a big, large area in green that we can go in and save. So this has revolutionized the world of stroke. Here, we still like to know last known normal, but ultimately we base a lot of our treatment decisions with regards to going to intervention, less on that and more on what these pictures look like, that there's a big mismatch, lots of green and very little purple, meaning we have something to salvage. So basically catheters are put through the groin that can be opened up around a clot that's sitting in there. And then there's a little vacuum that pulls the clot out. Down here in this picture is where you can see the clot sitting on a little tissue that's been pulled out by the interventionalist. Up above it is your before picture where the left middle cerebral has a cutoff. And then as you move over here, there starts to be some blood flow coming through. He's pulled a good portion of the clot out, and then the final result is down here on the right where you see when you compare the two, there's a lot of flow of blood into that left half of the brain that was not there before because of pulling out that clot. So very exciting stuff. So that's all I wanted to say about ischemic stroke for now. Hemorrhagic stroke, as mentioned, is much less common, but represents a good portion of all of our patients who die from stroke. These are patients who have very high blood pressure. When they're in the ambulance with you, they might be 220, 240, 260 systolic. They often have a history of alcohol or recreational drug use, increasing their risk of having this happen. Age is, of course, a risk factor, as well as something that you may not have heard of before called cerebral amyloid. This is something old people get that changes their blood vessels over time that we don't understand very well, that makes them bleed too. So these patients are a third more likely to die. They have long hospital stays. They have a lot more disability, and they frequently have seizures too. These patients, when they're heading in with you in the ambulance, as mentioned, it's a clue that they have the very high blood pressure. They probably had a headache at onset before they developed their symptoms. And they may actually fluctuate to worsen in the ambulance with you. They go weaker on the side, they become unresponsive, they need intubated. That's usually more consistent with a hemorrhagic stroke than an ischemic stroke. Okay, so that's basically all I wanted to say in terms of the basics of stroke in general. Now we'll go through some of the mimics for you, like seizure, migraine, sepsis, syncope, metabolic disorders, and conversion disorder. So I wanted to kind of give you an example of what you may have on the scene in the ambulance to kind of go through each of these one by one. But that'll be the next slide. Let me talk first about this. So FAST, as you know, is very sensitive for picking up 70 to 97% of strokes. But it's not very specific. In fact, probably only 13 to 30% of the time will it be correct that what we're seeing is actually a stroke. The reason this is important, in particular with the ischemic stroke, is we want to be right before we give somebody a clot buster like TPA. We know that TPA has risks. The benefit outweighs the risk if you're having a stroke, but the risk is that you can bleed. You can bleed in the brain. You can bleed in other parts of your body when we give you TPA. In fact, the risk of bleeding in the brain with a stroke, we say, is somewhere around 7%, but still is outweighed by the benefit of giving the TPA. That being said, the risk of bleeding in the brain, if we give TPA to a mimic, for instance, a migraine patient, is actually probably less, maybe about 1%, because there's not dead tissue in the brain that's going to bleed. So we actually do probably frequently TPA mimics, maybe somewhere around 1.8 to 10% of the time are we giving TPA to a mimic. So it's not the end of the world if we do. The risk of it is probably low, but we do generally like to be right when we're doing it. So what are the clues to it being a mimic? Remember at the beginning of the talk, we talked about marching. So in general, strokes come on very suddenly, all symptoms at once, maybe face, arm, and leg together, and there isn't a sequential change over time. That's what I call marching. The two things that march are seizure and migraine. So if a patient starts in the face and then a minute later moves to the arm, or 20 minutes later moves to the arm, it might be more likely to be a mimic rather than stroke itself. The other clue is that it needs to make sense based on that homunculus I showed you, and the left versus right connection. So if you're trying to put a clot somewhere in the left brain, then only the right side is generally going to be affected. So if you have somebody who has bilateral arm symptoms, bilateral leg symptoms, left face, right arm, it's usually very challenging to do that with a single clot sitting somewhere. So that's one clue too. Bilateral facial numbness, all of those things are much less likely to be stroke than they are to be something else if the symptoms don't seem to fit with that organization of the brain that we talked about. The other thing is the suddenness of it. My experience has been that people who have like a migraine symptomatology will say, hey, I got up for work and at some point my arm got numb, and then it, the leg was a little numb, and then I got a headache, and then they come in through, probably not you guys as much as through triage. They can't necessarily say the exact time of onset, versus with your stroke patient, it's 8:20, definitely everything all happened at once, and it was so sudden and it was so severe, they can say the time. So generally those are some clues that it's going to be to tell the difference between stroke and mimic. The other thing with regards to mimic, of course, is if you're young without much risk factors, and sorry to say as a woman, but if you're female, it's more likely to be a mimic too, particularly if you're young without risk factors. The likelihood of stroke is much greater if you have a history of hypertension, particularly they say if a diastolic is greater than 90. There was something called the brain attack study that said that that was more specific for stroke. So hypertension, you guys are seeing in the ambulance if they have a history of hypertension, AFib, hyperlipidemia if they're older, and of course if their eyes look funky on exam, all of those things are going to be more likely to be stroke.
Excuse me, Dr. Harle.
So when the
I'm sorry. One of our providers just asked a question about, she's sorry that they missed what you were saying about marching. Could you repeat that?
Yeah, for sure.
Thank you.
So it's a very helpful, important point. So when someone comes in and they feel like their symptoms are spreading, they don't start in the face, arm, and leg all at the exact same time, but it's in the face first. And then in 1 to 20 minutes later, maybe it's in the arm, and then another minute or two later, it's in the leg. That's what we call marching. It has this procession of spreading over the course of time versus happening all at once. So there's always some exceptions to that. There's occasionally some strokes where that will happen, but in general, when I hear of things that are spreading like that, particularly if it's going to be a younger woman, 40-year-old woman or something, it might actually be more likely complicated migraine. And seizures can do that too, and it can be hard to tell. But in general, marching is a clue that it's a mimic, marching meaning the symptoms are spreading over time through the body versus coming on all in a split second through that half of the body. Okay?
Thank you, ma'am.
Thanks. I can't see the window of questions, so I appreciate you just shouting out at me, because all I can see is my presentation on my screen. Any other questions? Or I'm all caught up on questions.
You are caught up on questions right now.
Okay, thank you.
Yes, ma'am.
So from you guys' standpoint, family member history taking, particularly since oftentimes a family member can't come into the emergency room so much so anymore, can be helpful in sorting this out. So if you can find out, do they have a history of epilepsy, history of multiple sclerosis, history of sugar or metabolic issues, if they've had recent infectious symptoms, all of that can be helpful too for background of making us think perhaps more likely a mimic. So here's an example. We have a 60-year-old gentleman. He might have been a little more confused over the last 3 weeks, but then one morning his family comes and finds him in bed, paralyzed on the right side, unable to talk. His last known normal was the night before. You note some very subtle twitching, irregular, of the right arm, leg, and face. So this is a seizure. This represents about 20% of mimics. This is what we call a complex partial seizure. So it's primarily affecting one side of the body. It can be subtle like that. ER physicians, ER staff can miss this, and then the neurologist walks in and we note it, and it can be so subtle that it can be like that for hours, unfortunately. So keep a strong eye out For any sort of subtle twitching in our stroke patients, that might be a clue it's actually a complex partial seizure. Something called Todd's paralysis was first defined in 1849. It's most often a situation like this gentleman who is unilaterally weak after a complex partial seizure. So in this case, it would be the left half of the brain over that motor strip would be where all the abnormal electrical activity is coming from, affecting the right body. But if it's moving down into the area that controls language, then there can be aphasia. If it's over a parietal lobe where sensation is controlled, the seizure may actually just be tingling of one side of the body. If it's in the frontal lobe where vision, gaze is controlled, the eyes are pushed to one side or the other, you can actually just have someone whose eyes are pushed to the side. There's a lady you guys respond to at Willow Valley, if you guys do Willow Valley, who's come in a couple of times now with that sort of a seizure actually. So, and neglect also that I've talked about a few times in the right parietal lobe from that sort of stroke or seizure leads to neglect. So it all depends where the seizure activity is coming from, just like with the case of stroke, as to what symptoms we potentially see. So what happens in a seizure is the tissue is stunned. It doesn't have enough metabolic products to function. So it almost looks like it has a stroke after it runs through all that energy. It's like running a marathon without having enough oxygen and sugar. So after that happens, you can have someone looking exactly like they have the weakness of a stroke, or a gaze preference of a stroke, or an aphasia of a stroke, or neglect, any of those sorts of things. And this weakness can last minutes, hours, days, any of those things before the patient comes around. But my key to note with all of this is look for subtle twitching. And this case I wanted to give as an example of we never TPA this, because actually the guy has been growing a brain tumor, let's say, for the last 3 weeks. That's why the family thought he looked a little off for 3 weeks. And this was his first presentation of his brain tumor. This is not an uncommon thing that we deal with, unfortunately. As you know, in the CT scanner, when someone comes in, it was actually a seizure, and it's actually a brain tumor that we see on their CAT scan rather than it being stroke. Okay, next case. 45-year-old woman with onset of right arm numbness and tingling at some point while getting ready for work. A bit later, she noted it was in her face and then her leg as well. You guys note she might have a slight facial droop on exam, along with some mild drift of the arm and leg on the right too. She has a headache coming on by the time she gets to the emergency room. This is migraine. This represents 9% of mimics. 20 to 30% of migraines have an aura. An aura is this extra stuff on top of the headache where we have changes in electricity, changes in blood flow as part of a migraine. And it looks like stroke depending upon where these changes are. The classic situation is visual because it often will start in the occipital lobes and then spread forward. But wherever the migraine physiology is located is where you're going to have the symptoms and what they're going to look like. So in some cases, it may start as visual with what we call a scotoma, where the patient has flashing lights or a kaleidoscope rainbow vision. Mine always look like I'm looking through stained glass. And it grows, the stained glass grows over a few minutes, and then it may spread forward, and the patient can say then, well, that gets better, and then I get tingly on that side of the body. And then I couldn't really talk very well, and I seemed confused. And then a headache came on after that. So that's the marching I was talking about again. In cortical spreading depression of migraine, there's a specific rate where the electric changes move forward, and it generally takes about somewhere between 10 and 20 minutes for it to move from one area to the next as these symptoms kind of grow, shrink, and then become the next set of symptoms. But depending where it is, if it's in the brainstem, there can be vertigo, there can be weakness. We see that often. Probably 1 in 10 stroke alerts is a migraine where someone comes in with weakness on one side of the body. So when symptoms are marching over the course of minutes, we think about this. The other thing that can be a clue is positive symptoms rather than negative symptoms. So remember I said that when the migraine started in the back of the brain, we have a visual scotoma, which may look like flashes of white light or kaleidoscope. It's what we call a positive sensory phenomenon. So there's an additive of color, an additive of light. It's not black. If something's a black hole or a black spot on one side of the vision, or a blacking out completely of one eye's vision, it's going to be much more likely to be stroke. So that's an example of a positive change in the vision area. You can also have positive changes with regards to sensory. So every now and then we'll get strokes that have pins and needles, but more often it's an absence of sensation of that side of the body, not an addition of pins and needles. An addition of pins and needles is positive sensory and maybe more likely to be migraine. This is by no means a hard and fast. The thalamic strokes can be positive, but this is just a general rule. Same thing with motor. If someone's twitching, if there's an increase in movement, it's probably less likely stroke and more likely seizure. So just another general rule to make us think things that might be mimic. So positive symptoms may be mimic. The other thing in migraine is you can have, as part of the aura, things like yawning, nausea, vomiting, trouble concentrating. All of that might point to migraine as well. And believe it or not, a good portion of the time, patients don't even have a headache with it. In fact, my older patients, in particular after menopause, may not have a headache with their aura. Here's another case for another mimic example for you now. So we have an 80-year-old with a history of stroke, has been coughing for the last several days, developed a temperature, then family noted he seems weaker on the right side in the face, arm, and leg. You are summoned and note he has a facial droop on the right and a right-sided drift. Blood pressure is low at 80/60 with a temp of 101. So this is what we call recrudescence, in this case from sepsis, maybe actually from COVID, who knows. But the point being that when people are old with a history of stroke or subclinical cerebrovascular disease, and they get sick, their brain doesn't compensate as well. And the symptoms of the old stroke can come out again and look exactly like they're having a fresh new stroke. So fever, low blood pressure, any sort of infectious symptom history you can take may point to this more likely being the recrudescence of an old stroke from an infection as opposed to a brand new stroke. Okay. Similarly, if we have an 88-year-old, how often do we have this story? At least I'm sure once every month you guys do this one. 88-year-old goes to the bathroom. Family finds him passed out on the toilet, weak on the left. As he's starting to wake up, he's mildly confused but improving quickly. But the left side is still weak, so they call 911. This is just like the last slide. Similarly, when old people have syncope, or maybe they have some baseline unequal blood vessel anatomy on top of it, they can wake up with unilateral deficits. Some clues that it's not stroke. Loss of consciousness actually isn't that common in stroke. If it is part of the picture and the patient is still minimally conscious, look for eye findings. And I'm going to talk about this more under the chameleon section, but and maybe this is more for the neurologist to always remember because we hate missing this, but if someone's unconscious and their eyes look funny with ptosis, meaning a droopy eyelid, or a blown pupil, or maybe they're quite disconjugate, like each eye is going in a different direction, this might be a basilar posterior circulation stroke. But if the patient passes out and then wakes up again, like this guy did, then find out a prodrome for us, if you can, from the family member in particular. Did they look pale before they passed out? Being pale before syncope is a big clue that there was a low blood pressure, potentially a vagal episode, something like that that caused a patient to pass out. So I always like to ask any family members who may have witnessed it if the patient looked pale. The patient, as they're waking up then, can be asked, did you feel sick to the stomach beforehand? Did you break out in a cold sweat? I don't know how many of you have ever had a vagal episode before, but it's hard to ever forget once you've had one. Your stomach is really upset. You may feel like you need to have diarrhea. There's ringing in your ears. You're breaking out in a cold sweat. All of those things can be a clue that the syncope was vagal in origin. And when you're old and you vagal, you may wake up looking like you've had a stroke. So other clues are what the situation was when the syncope happened. Was it during urination or defecation? Was there a big coughing spell? Any of those things are very common to do it. Have you just eaten a big meal? Are you dehydrated? Was there a recent increase in blood pressure medicines? All of this may point to a syncopal etiology that then led to the stroke-like symptoms. Very quickly, metabolic issues. From your standpoint, you guys all know that a super low blood sugar or a very high blood sugar is important to rule in or out because that very frequently can mimic stroke. But other things like a very low sodium, thyroid disease, liver disease also can mimic it. When patients' blood pressures are higher or there's severe calcium abnormalities, you also can mimic a stroke, hypertensive urgency. And one thing that we as neurologists always have fun trying to rule out is something called conversion disorder or a diagnosis of exclusion. So this is frequently your 40-year-old hysterical woman coming in very stressed and depressed who can't move one side of the body. So one thing they always say to help with this is labile indifference, that there seems to be this disconnect, that they're not that freaked out by the fact that they're paralyzed on one side of the body. Maybe there's no clear time of onset. And the neurologist does an exam to figure out there's giveaway weakness. That means there's this inconsistent effort when we're testing them on their shoulders and their biceps and their hip flexors, for instance, that they give a burst of effort and then they give way. There's drift without pronation. And since I don't have a camera, this makes this hard. Maybe I can, let's see if this works. I'm going to try and pull up my camera again. Okay. So when we ask our patients to hold their hands out, one thing that fake weakness will do is this. The arm goes down, straight down. And no one who's faking knows that that's actually wrong. So that's a subtle clue the neurologist uses to actually figure out, do we think this is fake weakness or not? Because what really happens at first when someone's weak and you ask them to put their hands outstretched like this is you drift. The first thing that happens is you drift in and then the arm goes down. So that's a little cheat to tell the difference of is it real or not. So this may be fake, drift, and then down is real. Okay. And then finally, the Hoover test is pretty cool. So in this patient in the picture where we're doing the Hoover test, they're saying, hey, their right leg doesn't work at all. Okay, they won't give any effort lifting their right leg off the bed at all. So the examiner puts their hand under the heel of the right leg and then asks the patient to lift the left leg. And you guys can probably note this yourself. When you attempt to lift your left leg and you're laying on a bed like that, you actually push your right leg down into the bed subconsciously. So what the examiner can then feel is they actually have some strength in that leg. They just extended at the hip and pushed the heel down on the right while they were lifting the left leg. So that's another little tricky test we can do to try and figure out, is it real or not? But as mentioned, we TPA conversion disorder not uncommonly. Every time I come on call, I might get a sign out, which is like, okay, this one wasn't real, but I just did it. Because again, as mentioned, risk benefit usually favors it. If somebody doesn't have a true stroke and doesn't have dead dying tissue in their head and they're young, and well, we're probably just going to do it because the risk of missing treating a stroke is pretty high. The risk of giving TPA and having a bad outcome in patients who aren't having a real stroke is pretty low. So we can do all these tricky little tests, as I mentioned, but in the end, oftentimes we may just err on the side of caution and try and do it anyway and sort it out afterwards with an MRI. MRIs are very sensitive for telling us whether it was real stroke or not. Oh, I'm not sharing this the right way. Here you go. Okay, so that was the end of my mimics. Chameleons are strokes, but they don't really look like strokes. So I thought this one is always really fun and from an academic standpoint to point out. This goes back again to these right hemispheric strokes and how interesting the brain is to the neurologist in terms of its organization, where you can put problems, as shown in the scan, in the right posterior portion of the parietal lobe and make people not know they have a left half of the world. But beyond that, they can actually be acutely confused. So in this case, someone just gets called that they're acutely confused. 75-year-old woman, sudden onset of confusion. She's really restless, but there's really no focal weakness. There's no drift. There's nothing really on exam there's no facial droop, nothing to suggest stroke. It's just a big change in her mental state very, very quickly. So that points to this right posterior area. This area does other high-level things. So the clue on our exam, when we check her, or you could as well, is that there's a left homonymous hemianopsia. So the vision may be out in the left half of the world. So both eyes on the left-hand side may be missing vision. And if you ask them to draw a picture, they don't draw the left half of the picture. So, so that's just a cool one. That's acute confusion, but can actually really be a stroke. This one, hopefully I can get to work, is called hemibolismus. This is a movement disorder. Remember I said usually people are weak and not moving, but you can actually have extra movements as part of a stroke.
Hemibolism is an involuntary movement disorder affecting one half of the body. It usually results from cerebrovascular accidents involving subthalamic nucleus. It is characterized by sudden flailing, intense and violent movements. These movements are continuous.
Oh, okay. I don't think he was going to say anything else that we needed to hear. But the one thing you note here is, of course, it's the right half of the body doing it. So it's the left side of the brain, in particular the subthalamic nucleus, that has the stroke. And it's an interesting movement disorder. You may have seen things like this before in cocaine overdoses or other sort of stimulant overdoses, but it would likely affect both sides of the body, that you have interesting new movements versus just one half of the body. So that's maybe one way to discriminate. But certainly there's drug overdoses that can give weird flailing movement disorders like this too. And then finally, this is every neurologist's worst nightmare when it comes to ischemic stroke. Remember when I said loss of consciousness isn't usually a stroke, but then I went on to say occasionally it is when it's posterior circulation. So on this CAT scan, there's a little white spot in the basilar artery, the artery coming up the back of the brainstem, which is clot. So in a patient who has sudden onset of clot over the brainstem, that's our area of the brain that controls everything that keeps us alive, breathing, swallowing, all of that, being alert and awake. If you clot that off, you're going to be unconscious and essentially die. So this is a patient who may have a history of AFib, older, and presents with, first there's usually vertigo. So there may be some dizziness, room spinning, and then they lose consciousness. I've been fooled before because you get a story of seizure. They actually have flailing movements. I don't know why that, oh, there we go. Flailing movements, and it's not seizure, it's extensor posturing. So they may actually posture at a high rate of speed. You guys may have seen that decerebrate, decorticate sort of back and forth, arms extending, and all of that isn't actually seizure. It's clot sitting in the basilar causing posturing. And these patients may acutely go unconscious, become half conscious, then become agonally respiring. You need to intubate them on the way in, or when they get to the emergency room. And they have funky eye findings. That's the biggest clue of all in these basilars. One eyelid may be half droopy and down with a blown pupil. And then they're weak on one side of the body more than the other. But the big clue is the funky eye changes. So a basilar, fortunately, is much less common than the MCA ones we've been talking about today, but it's very devastating. You will definitely die from a basilar artery stroke. We go out to 24 hours intervening on these because of the likelihood of death associated with plaguing off the blood flow to the brain stem. So here is an example where there's a clot sitting at the top of this artery, and then they pull that clot out to let the rest of these arteries fill up. So clot at the top of the basilar, clot removed. Sometimes these patients still don't do well after we get it out because it's a very hard situation to deal with, but it is certainly one from an endovascular standpoint that is very much something we need to go after and try to fix, because otherwise this is uniformly a 100% terminal type of stroke, unfortunately. And that is actually all I have. So I am up for questions if you guys have any for me now.
Dr. Harle, one of the questions, can you hear me okay?
Yeah, go ahead.
Okay. One of the questions I had was, and I might have missed it because I had to step out for a few minutes, but we talked about different causes and stroke mimics and chameleons. But one of the things that we teach, new providers is some things like overdose and even mental health issues can cause certain types of psychiatric disorders can cause stroke-like symptoms. Do you have any thoughts on that?
Okay, so overdose, I think I showed you the hemibolismus slide in terms of disorders. So cocaine stimulants in particular. Now, if you're going for the depressant sort of overdoses, then the patients are unconscious and their pupils will be teeny tiny versus blown, as is the case in strokes generally. So perhaps that's a little bit of a clue potentially too, that you're going to have a fentanyl or an opioid sort of overdose causing loss of consciousness versus the basilar artery occlusion causing loss of consciousness, or a big brain bleed causing loss of consciousness. I imagine the blood pressure might be a little different and low in your overdose versus very high in a hemorrhagic stroke, making you completely unconscious, or a basilar stroke. That might help too to discriminate. So psychiatric disorders causing stroke. I did have a slide on conversion disorder, and that might have been the one you missed. So people with mental health issues can develop weakness on one side of the body, but some of the clues are labile indifference, that they seem to be, and you can stop me if you heard all this already, that there seems to be a disconnect, that they're less interested in the fact that they're paralyzed on one side. And then there's some clues on the physical exam that they may be weak, that they're kind of inconsistent. And I didn't show this, but I'll raise an arm over the head and it'll hit them in the head if they're truly weak. But if they're not, they'll move it down to the side so it doesn't hit them in the head. I should have gone over this one because this is one of my favorites. So definitely, if you think somebody is faking, put the arm over their head and see if they knock their head with it versus like put it back down. The other thing I'll do is pinch. Go ahead. What were you saying? I'm sorry.
That is something that we do occasionally. Just, when we get a suspicion, at least some of us older folks do. I don't know about the younger generation, but that was just, nobody wants to hit themselves in the face. So
right. Yeah,
okay.
That's a little tricky one. Right. The other thing would be pinching. So very significant weakness, numbness on one side of the body. If somebody's faking and you pinch them, they may withdraw, of course. But if they're super weak from a real stroke and you pinch them, they're going to grimace and look really angry at you, but they're not going to be able to withdraw. So that's another thing too, that maybe the neurologist more than you guys are comfortable with in terms of inflicting significant pain like that during an exam, unfortunately, but that's another thing. I talked a little bit about the drift. That's more subtle. So that's the one where the hands are out here and it turns in, and then the Hoover test is also a hard one to do in the field. But those are some other potential things that can be considered.
Okay. All right. Thank you for that.
Okay. That was a good hard question. Do you have any other hard ones for me?
Hi, Dr. Harle. My name is James Rohr. When looking at the eyes, are we going to be more commonly seeing unilateral eye abnormalities, or is that going to be a bilateral thing? Okay,
yeah. So if it's a basilar artery, it's usually one eye that will have ptosis and a blown pupil, at least at the point that they're first presenting. It always seems to be a little bit worse on one side more than the other. So that's with the posterior circulation stroke we're talking about, in terms of the actual lid being down and the pupil being asymmetric and quite large. That will change over time, but probably not acutely in the field very quickly when the patient's coming in with you. The other thing I would point out that's very different from a homonymous hemianopsia. So in many other types of strokes in the back of the brain and over this area, you can get a homonymous hemianopsia. The cortex, all of the radiations from the eye all cross back through to get to the occipital lobe. So there's many areas in here where you can develop if the stroke is large enough, not in a lacunar one, not in that teeny tiny one I showed from hardening of the arteries that are diabetic, hypertensive, hyperlipidemics get. They don't get the homonymous hemianopsia. It's more when you clog off one of the large arteries like the MCA or the PCA that you'll develop that. And that's the test where we cover an eye and have the patient count fingers, or we flick them in the face. And because both eyes come from the opposite side in the back, so if you have a left occipital, then the right side in both eyes is affected. But you can get that just from over here. So in the case of a left PCA, this portion of my vision, so this is my right eye, this is all confusing because it's backwards in the camera, but a left PCA would make the right side unable to see over here, but it would be fine to see here. So, oh goodness, there's a hard question about a Cincinnati stroke scale popping up over here, which I may not know the answer to, but the bottom line is a homonymous hemianopsia affects both eyes. But that has to do with finger counting as opposed to the unconscious patient who you're just trying to get a sense of what's going on with their eye exam. So if I have the left PCA stroke in this eye, I can't see here, but I can see out here. Okay. Hopefully that makes some sense.
Yep, thank you.
It's very hard doing it in a camera screen backwards, I think, for everyone. But the bottom line is both eyes lose a hemi field based on the opposite side of the occipital lobe or the rest of the hemisphere that it's crossing through.
Dr. Harle, there's two questions that are posed. Jackie Grice is asking, can you, Bell's palsy and how it compares to stroke?
Yeah, that's a really good one. So when a Bell's palsy begins, it's usually a little bit more subacute. When you really go back and talk to the patient, they may say they felt some tingling or some numbness or a little pain behind their ear beginning the night before. And then they're up brushing their teeth the next morning and they notice everything's dribbling out the side of their mouth and their face is drooping. So it will get called kind of suddenly because sometimes the weakness is noted very abruptly. But in getting the history, there may be a touch of some symptoms in retrospect that are mild in the hours before. And then the main thing is the droop is profound in the lower face, but then they also can't raise their forehead. So when you ask them to raise their eyebrows on that side, there would be no forehead wrinkles. They also oftentimes seem to have that their eye on the lower lid side is a little droopier as well. But the big thing we always ask is when they smile, that one side is not going to come up, and then they also can't raise the eyebrows on that side, and that would be more consistent with the seventh nerve related problem, which can occasionally be a stroke, but is more often a Bell's palsy. If it's a seventh nerve related stroke in the brainstem, the seventh nerve is right on top of the one of the eye nerve nucleuses, one that moves the eye laterally, so they frequently aren't going to be able to move their eye to the side either. So it would be very hard to have a stroke causing the forehead weakness without also having a weird eye movement change. Those patients are awake and alert and talking with you and would be able to follow your finger, and you would see that the same side where they have the facial droop, they wouldn't be able to move their eye over.
Okay, thank you for that. Next question. Why is the Cincinnati stroke scale seem, I'm just kind of moving around. Oh, Tracy's answering it. Why does
Thank you, Tracy. Neurology isn't very familiar with the scales you guys use. I'm so sorry.
preferred instead of the race scale, or are they about equal? And Tracy answered, the Cincinnati stroke scale comes from the state, so it's what is the minimum, but the M-race scale is an optional and one that is very appropriate, much more appreciated if you do or share with medical command when you call. It's actually a more detailed exam than what the Cincinnati stroke scale is.
Wow, I'm learning things too. Yeah, we speak, unfortunately, very differently. Hopefully, We used race, I wasn't sure. Hopefully that answers all of it. In neurology, we only ever talk using the NIH stroke scale, which is a lot more challenging to perform quickly. So you guys get down to the nitty gritty quickly with what you're doing. And then we add all the subtlety of counting the fingers and the finger to nose and neglect and all that sort of stuff when we do ours and calculate that as the what's called the NIH stroke scale.
So there's no more questions posed in the chat. Does anybody have anything else for Dr. Harle? For Dr. Harle, I'm sorry.
I have a quick comment about the M-rays.
Go ahead, Calvin.
I think one of the reasons that we recommended starting using the M-race is because M-race has a higher specificity for large vessel occlusion. So with our starting to do clot retrieval, it makes sense that we want to recognize those patients sooner rather than later.
Excellent.
I think that makes a great point. Tracy, would you agree with that? Yes, Calvin is exactly correct. Thank you, Tracy.
I think the next time I give a talk to EMTs, I have to look up your scores. And that being said, I'll just look like an idiot trying to talk about things you guys know more about. So I'll leave it to Tracy to fill in, I suspect. I'll just talk about what I know about.
No, we appreciate what you're doing. We really do. All right. Anything else for Dr. Harle? All right. I'd like to remind those of you that are on. I have the majority of you as far as your content or your provider numbers, but there are some that are still missing. If you have not put it in the chat, please do so. And I would greatly appreciate it if you want content credits. Anybody have any final questions or any opinions or anything they'd like to ask Dr. Harle before we let her get back to her evening?
I hope that was all good for you guys in terms of learning and understandable.
In my opinion, I thought it was great. Tracy is also reminding us that that don't forget the 18-gauge angio in the right AC. If at all possible, it's always greatly appreciated by the hospital.
That's funny.
Yeah.
And last known normal. I think you guys all know that and do a good job with that, though, too, because we went over that years ago, drilling that in.
Right. So, okay. And if nothing else, then Dr. Harle, thank you for your time and your expertise. And it's great having your time. And we very much appreciate it.
Thank you. I appreciate all you guys always do for us. Take care. Bye-bye.
Bye-bye. Thanks all. Have a good night. Be safe out there.
Andy,
Yes, sir.
Andy, when you shut off, make sure you please remember, since you've logged in, everything will be downloaded to your computer,
Right.
as far as the chat and the recording. So you'll need to put that onto a drive or something like that and get it to where we can post it.
Yes, sir. All right.
All righty.
Thank you.